Hi there, my name is Mike Sullivan. I'm the Program Director of Valor Medical Services. I'd like to welcome you to this presentation from our series of continuing education for pre-hospital providers. Now, before we begin, there's a few things we need to go over. First off, the information presented in this program is intended for use by trained EMS providers. Also, due to variations in protocols and scope of practice among different states, departments, and agencies, this program may discuss or depict procedures, medications that are not acceptable in your daily use. If you see something in this presentation that varies from your agency's policy, always follow your department's protocols. Also, none of our authors or presenters of this program have any conflicts of interest or financial relationships they need to disclose. We do have documentation of this on file available in our office upon request. While we do our best to make sure that all the content we present is the most current available, participants are reminded that medicine is indeed a dynamic science and thus changes rapidly. So things may have changed since we've written or compiled this program. Please always follow the most up-to-date information available. In closing, if you have any questions about this or any of our other programs, please email us at info@valormed.net. Thank you very much and welcome to the program. Alrighty, now that we've got all that legal stuff out of the way, before we get started, let's talk about coffee for a second. If you're looking for a great cup of coffee, you probably want to check out coffeebrandcoffee.com. They're an online retailer, American owned and operated. They have a wide variety of coffees, teas, hot cocos, all sorts of different flavors. They've got all sorts of organic teas. You can get coffee in bean form, ground form, K-cups, whatever your heart desires. I've had several of the different blends and several of the different flavors. Absolutely fantastic. And because they are an American-owned small business, they don't have a big warehouse, so they don't have a big supermarket sales business. They roast it, they bag it, they ship it to you. It'll pretty much be some of the freshest stuff you'll ever get. Definitely highly recommend them. And they've got a promo code out for us now. If you use promo code VALOR SDS, you get a 5% discount off any order. So you can save a little money, try some fresh coffee, see what you like. They've always got different flavors coming through on their website. Some are permanent, some are limited time only. And if you look right there in the picture, you can see they've even got, yes, double caffeinated. Definitely a winner around this office. Alrighty, now let's get to class. Hi, my name is Mike Sullivan and I'm one of the instructors with Valor Medical Services. In this presentation, we'll be discussing the assessment and the initial approach to a pediatric trauma patient. Overall, we're going to begin to identify some of the common mechanisms of injury and the profiles resulting from these occurring with infants and children. We'll review the EMS approach to pediatric trauma patients. We'll review how different mechanisms of injury can affect children differently. We'll predict possible injuries based on the mechanisms that the patient is subjected to. And lastly, we'll review the steps and phases of pediatric assessment. Now, as we look into infants and children or pediatric patients as a whole, let's look at the anatomy for a moment. Pediatric patients are going to have a head that is frequently larger in proportion to their body. This results with a tendency for falls to land head first. A fall greater than 20 to 30 feet, most likely the child will end up going in head first or impacting the ground head first. This will also increase the risk for drownings, even in small amounts of water, say a bucket or a toilet. A small child or an infant who's leaning over and splashing around or playing with the water in the base of a toilet, well, once they lean too far, their head overcompensates and they'll actually fall in and be unable to dislodge themselves even as they're drowning. This can be further compounded by the fact that the walls of the toilet, porcelain typically or some type of china, will be slick or slippery. So as the child's trying to push out, they're unable to get any traction and they can drown very easily. The same thing could occur in a mop bucket. Another concern we have is that pediatric patients are typically going to have a lot less muscle mass or body muscle mass than adults. Therefore, their vital internal organs are much less protected, less padded. They're going to be much closer to the surface and more vulnerable to damage or injury. Pediatric patients also don't have the metabolic or physiologic reserves that an adult would have, which would help an adult compensate longer. Once a child starts going downhill, this is going to happen much more quickly. Now, pediatric patients compensate longer. However, they'll decompensate more quickly than their adult counterparts. When we look at pediatric airways, their airways are going to be smaller and more easily occluded or damaged than an adult's. Once a child begins to mature, becomes an adolescent, and onward into adulthood, the tracheal rings will become much stiffer and therefore much more protective of the airway. This doesn't happen with a neonate or a small infant. Pediatric bones are more flexible. Thus, they may suffer partial or green stick fractures readily. The flexibility of their bones can also limit the protection that ribs provide the thoracic cavity. In many cases, we find that children who have a significant thoracic cavity impact may not have an actual broken rib or cracked ribs or broken sternum. However, these flexible bones will allow the impact to be transmitted into the heart or lungs or other great vessels in that cavity. We know that pediatric craniums are not fully developed. Thus, they may be more susceptible to traumatic brain injury or closed head injury, even with what would be a seemingly minor impact for an adult or an adolescent. So, given that, we have to look now into mechanism. One of the first steps when we evaluate a trauma patient is to determine the types and amounts of forces that the patient's body was subjected to. Put another way, what hit the patient or impacted the patient? Where on the patient did the impact occur, and how much force was imparted by this impact to the patient, and what was the result to the patient's body? Now, although mechanism of injury does not and never will directly correlate to the presence of an injury, when we evaluate mechanism, it should increase your index of suspicion regarding potential injuries. If we know a certain amount of force or a large amount of force impacted a patient at a certain point on their body in a certain way, we can suspect or increase our index of suspicion that that area of the body could be injured in a certain way. So although mechanism is not an absolute, it is a great place to start to try to figure out what might have happened and what potential we're dealing with. Now, when we look at some of the most common mechanisms of injury, for children, the number one is falls, followed by motor vehicle collisions, car versus pedestrian impacts, bicycle injuries, and lastly, burns. Now, when we talk about falls, this is one of the most common mechanisms that you'll see for a pediatric patient. Now, the average fall patient is about 5 years old. Different age groups fall from different places based on their lifestyles. An infant may fall from a bed or roll off a bed, or a couch may fall off a changing table if left unattended. They may fall out of a high chair or a booster if they're trying to get out of it. Now, preschoolers, they tend to explore more. They tend to be more independent. They may fall from windows or decks. And one key thing to think about when we talk about preschoolers with windows, think about the little child who leans out the window to wave at a friend or to wave at a vehicle going by. Once they lean so far, like we said before, their head and upper body being heavier, when they become off balance, their center of gravity will shift and they'll topple out the window much more readily than an older child would. Now, when we look at older children, teenagers, or adolescents, they may fall from dangerous play areas, tree houses, sometimes roofs, climbing up on buildings. They may fall from fire escapes. Typically, these children tend to explore a lot more. They tend to be a lot more independent, maybe not as supervised as readily as a younger child would be, and they tend to push limits. They are going to do things that most adults would say, why would you climb up on the roof? Why would you climb that far up on that tree? Why would you try to build a tree house on that tree that wasn't stable? They don't realize in many cases the consequences or the potential consequences of a bad decision. We talk about them being 10 foot tall and bulletproof. They believe that nothing can possibly hurt them, and unfortunately this leads them into dangerous areas. One statistic we found was most fatal falls occur from 22 feet or higher, or when a child lands headfirst on concrete. The interesting thing, when they talk about a fall of over 20 to 30 feet with an infant or a preschooler, most likely those children will be landing headfirst due to the heavier body. Now, falls represent, fairly common mechanism, and so we want to evaluate this and ask the following questions. What surface did the child land on? What part of the child impacted first? Did they land flat on their feet, on concrete, in which case we may have shock sensations sent up through the legs, may cause knee or hip problems, may cause lower back problems? How high was the fall? Was it off of a picnic table or was it off of a patio roof? Was the fall direct, or did the child bounce off several other objects on the way down? We don't like to think about it, but if a child, say, is climbing a tree and they lose their grip and they fall, they may actually pinball off, having several minor impacts on the way down, as opposed to a direct fall from, say, a window to concrete from the same height. Each one of those impacts can cause separate and distinct injuries, and in many cases, it may mask another pattern of injury because there are so many impacts to deal with. Now, when we look at it as a motor vehicle passenger, we want to look at various factors, including the impact speed. How fast was the vehicle going when it impacted? Was it a sudden stop or was it a gradual stop? A vehicle going 60 miles an hour down the interstate loses control, hydroplanes, and slides into the median strip. The vehicle may go for 100 feet or 200 feet through grass, may bounce off cable barriers or other barriers, and may go from that 60 miles an hour down to zero very gradually over a distance. On the other side of the coin, the same vehicle going 60 on the same road loses control, but instead of going into the grassy median, they end up losing control and slamming into a bridge abutment. In that case, they went from 60 to 0 very, very rapidly. It's going to be a much different impact. So we look at the speed, but also the rate of deceleration, or how well, did it happen suddenly or was it gradual? The type of vehicle they're in. Larger vehicles may provide more protection. They may actually sustain through vehicle damage better. What type of collision was it? We look at, was it a rollover? Was the child restrained? Various things like that. Was, again, a sudden impact or a gradual impact? Was it a T-bone impact that came into the side of the vehicle right where the child was seated? Or was they rear-ended and the child was in the front seat? Where the child is in the vehicle can play a big role based on how close they were to the impact, number one, and how much intrusion there was. How were they affected by this intrusion? If there's no intrusion near them, then the passenger compartment did its job and protected the cargo very well. A big thing we start looking at is child restraints. Now, a lot of people say child restraints is a simple yes or no. Was the child restrained? But wait, there's more to look at. Was the child restraint properly secured on the child, or were they half in, half out of it? Was it a child who was trying to get out of it and had already loosened it? Was the child just sitting in it but not restrained properly? And also, was the child restraint properly secured to the vehicle? Putting a child in a child restraint perfectly but failing to secure the child restraint properly doesn't do as much good. Were there other passive restraints involved? Were there airbags involved or other things? We also need to look at what secondary impacts there were. In today's modern SUVs and crossover vehicles, the open back, while providing a lot of great storage, can allow objects from the trunk area to fly up into the passenger compartment that wouldn't happen in a conventional sedan. These objects could be everything from a bag of potato chips, which would not be that dangerous, to a 6-pack of soda or a 12-pack of soda, which, if hitting a child in the back of the head, could do some significant damage, especially if it's airborne at 40 or 50 miles an hour. The box of Kleenex in the back window isn't going to cause as much damage as the big metal umbrella that's in the back window. Now, when we're looking at mechanism of injury as far as a pedestrian injury versus a car, we need to, again, look at the impact speed. A big concern we'll have is the type of collision. When we say type of collision, was the child just glanced by a passing mirror? Were they hit and knocked under the car? Were they go up and over? Was the child bumped and knocked down, or were they dragged? The point of impact, not only on the vehicle, but also the child. Depending on the age of the child, standing next to a car, an infant or a toddler may get a bumper in the rib cage, while an adolescent may get a bumper in the femur, while an adult may get that same bumper in the knees. Now, while an adult getting a bumper in the knees at 20 or 30 miles an hour would be painful, yes, there'll be damage. However, that same bumper hitting an infant in the rib cage, a toddler in the rib cage, is going to do a lot more life-threatening damage than messing up an adult's knees. Again, was it a down and under? Did they get run over by the car itself? Did they get hit by the wheels? If they actually got run over by a tire itself, or just run over by the car where they went underneath the car, were they drugged? Were they burned by the exhaust? Were they pinned under the car for an extended period of time prior to our arrival, trapped by a hot exhaust? We also have to look at secondary and tertiary impacts. These would be other impacts after the initial contact. For example, a child runs out in front of a car, gets hit. The initial impact might be the bumper. The secondary impact, if the child goes up and over, may be their head hitting the windshield. The tertiary impact could be either them falling off the windshield or going up over the top of the car and landing behind it. However, let's say a child is clipped by a mirror of a passing motor vehicle. The primary impact would be the mirror hitting the child. The secondary impact would be them getting knocked down. Did they get knocked down onto concrete or onto a grassy shoulder? Was there a sign there or something else that they could have possibly impacted? Each one of these impacts we need to look for and try to figure out again where the impact occurred to the child and what potential areas could be injured by these impacts. One more thing to consider, although it's not directly listed here, is what type of vehicle struck the child. A smaller car or a sports car, such as, say, a Mazda Miata or even a Corvette, they're going to not only have a very low impact, but more likely to have an up and over impact, as opposed to, let's say, the front of your ambulance or the front of a school bus or something like that, which again is going to have a much larger surface impact and is going to impact much more of the child. Was it a motorcycle? Was it a motorcycle versus a moped, say? Both of these are going to have a lot different impact as they strike the child. So look at what type of vehicle it was and try to picture how your child or your pediatric patient is going to match up to the front of that vehicle, because that vehicle type will let you know a lot about where you had your impacts. Now, when we talk about bicycle accidents, generally bicycle accidents are not that bad. However, the most devastating injuries in bicycle accidents are those that involve head trauma. One way to prevent these injuries is for riders to wear helmets. Bicycle helmets are proven to reduce the risk of head injury in bicycle accidents by over 80%. They're very, very effective, and they're typically single-use items or single impact items, and once one has been damaged or has been in an accident, we need to go ahead and replace it. Ideally, all children riding bicycles, regardless if they're riding alone or as a passenger on another bicycle, should be wearing a helmet. If you look at the picture here, interesting to note, the child is at a significant height off the ground. That child, if they do fall, is going about 5 feet at least to the ground? So therefore, having a helmet in place and that child seat is not only going to provide head protection, but also some lateral impact protection if the adult happens to lay down the bicycle or get knocked off of it. These type of things can be done, and it takes a little planning, but having a child properly restrained in a bicycle safety seat and also properly, wearing a helmet, that child is going to be far safer than one who, let's say, is just hanging on or just riding loose on the bicycle or not secured properly in the seat. Now, when we look at burns, thermal burns are the most common type of burns suffered by a pediatric patient. They may result as a result of exposure to hot liquids, flames, steam, or even contact with a hot object. Many times children won't recognize an object as hot, and therefore they'll intentionally or accidentally touch it. It may be glowing bright red, and that may make them curious. Burns may occur accidentally, if the child's curious, or they don't realize what the danger is, or they can be the result of child abuse as well. Now, the severity of burns is based largely on the depth and the area involved. If you have a patient with known or possible airway burns, providers should always suspect an airway compromise. Some of the signs of this would be hoarseness, singed facial hair, wheezing, stridor, or the presence of soot in or around the airway. Even though we may not see an airway burn initially, we know that this can be something that will rapidly develop, and we need to be aware of it and plan for it in advance if we see these warning signs. Now, when we do our assessment for a child, our size-up begins en route and continues upon arrival. We want to be thinking about what the safety profile of the scene is. Are there hazards there that we need to mitigate? Possibly leaking materials, wires down. Is there a traffic hazard? Is there a chemical hazard? We need to think of how many patients we have. Again, most children aren't in a car alone, so therefore we know we're going to have adult patients as well, or other patients involved. Do we have multiple children involved? A wreck with a church van with 15 patients can do a lot of taxing to a system. Additional resource needs. Do we need a second or third truck? Do we need an air transport unit? As we're en route, we need to think about, okay, they're saying it's got pediatric patients involved. Where's not only my closest trauma center, but where's my closest pediatric specialty center? Can all the hospitals in the area admit pediatric patients, or do we have to call additional resources because we'll have to go to a specialty center? We need to think of what type of mechanisms are involved. Is it an interstate highway, or is it a parking lot? While either one could be fatal, we'll suspect a higher mechanism of injury going to a highway than we would, say, in a fast food parking lot. All of this can be taken into account while we're on our way. What's our best transport locations, our routes of access and egress? Are we going to have multiple patients? What is dispatch telling us? Is it a one-car wreck off the roadway, or is it a school bus that's rolled down an embankment? All of this can give us an idea, and by calling additional resources early, we'll get them there more quickly. A good thing to think about for those of you all in supervisory capacity, if we're responding into this, whatever your agency's policy is, if you think you may need specialty resources, get them on the road to you, at least non-emergent response, or possibly emergent response based on what you're hearing. We can always cancel and send them home. But if you work in a rural area, the longer it takes you to notify them, the later it's going to take them to get there, and the longer you'll be alone on scene with multiple patients potentially. Now, as we start looking at the patient individually, our pediatric assessment triangle starts with basically a visual assessment. We perform this as we approach the patient, as we walk up on the scene. What is the child doing? How do they appear? Are they up, walking around, conscious? Are they crying? Are they laying on the ground unresponsive? Are they in a child safety seat? Does it look like the seat was ejected from the vehicle? What's going on with the child's breathing? If we look at the child itself, does it seem like they're struggling to breathe? Are they screaming and crying and we can tell they've got an excellent airway? What does their circulation look like? Are they limp, lifeless, and pale in a puddle of blood? Or again, sitting up and reacting normally? Do we see any obvious bleeding, major injuries? We can tell as we walk up to a child, their legs should not bend like that, and I don't think their arm looks normal. Or do we see a child that's, again, ambulatory on scene or being carried by parents? This can give us a very quick preliminary determination of how critical the child is versus non-critical. Again, since children typically aren't in cars on their own, we're going to have other people there with them. We're going to have adults, patients from other vehicles potentially. So we'll do our assessment, and we're trying to figure out, okay, triaging the child, are they critical, are they non-critical, what do we need to do from here? Now, when we start our primary survey, this is designed to be a rapid evaluation for any immediate life-threatening injuries or conditions, address these life threats as we find them, correct them as quickly as we can, and work from there. Initially, we'll do airway and C-spine. We'll then address their breathing, any circulation or bleeding issues, disability or mental status, and lastly, expose and evaluate the environment, and is there an environmental component to their situation. Now, if we suspect C-spine injury, we should manually stabilize the head in a neutral inline position. Good reasons to suspect C-spine injury is a child with unresponsive or altered mental status, a child with a significant mechanism of injury, let's say hit by a car and knocked up over the top of it, a child with blunt trauma above the nipple line, any complaint of pain in the back or the neck as we palpate, any numbness or tingling or loss of movement or sensation in any extremity, any multiple traumatic injuries where there's potentially distracting injuries. For example, the child has a significant impact and they have an obviously broken, deformed arm, and they're very concerned about their arm, and they may not realize that their neck or back is also hurt because they're not feeling any pain in that right now. They may not even realize that they can't feel or move their legs because they're very concentrated and distracted by the arm injury. They've got a bone sticking out of their arm. It hurts very, very badly. It's very, very gruesome to look at. They can see that and know all about that, and not realize that they have no motor function below the waist. Now, given the size of the child's head in proportion to their body, we should need to pad underneath the child's torso to complete the immobilization. Our goal is to get the child's head in a neutral position. Basically, their face when they're lying on the backboard should be parallel to the ground. However, due to the prominence of the back of their head, if we don't pad, typically the head will be cocked forward with the chin down towards the chest. This not only can take away a large percentage of the child's airway, but it also prevents a good neutral position. If we need to actually manage the child's airway later on, that position will also make life more difficult. So try to stabilize as much as we can in a neutral position with the face plane horizontal to the ground. Now, as we evaluate the child's airway and the patency, if the patient is conscious, they may be able to protect their own airway. They're conscious, they're talking to us, or they're crying. Look at the airway quickly. Do you see blood or copious secretions in the airway? If we do, consider suctioning. Ideally, if we see a child with an airway compromise that we have to suction out, we should try to station a suction unit with the patient after being used. This is especially true once the patient's immobilized. Think of a patient on a long spine board totally immobilized. If we've done our job properly immobilizing them, they are unable to protect their airway now, and we need to have someone assigned to that airway with a suction unit ready to intervene if the child begins vomiting or anything else. If we leave the child unattended on the backboard in this position, if something goes wrong and they begin to vomit or blood begins to accumulate, they can easily aspirate and be unable to do anything to protect themselves. Now, if the child is unresponsive, you may need to open the airway. Typically, with a trauma patient, we'll use a jaw thrust if at all possible. Now, if we absolutely can't get a good airway with a jaw thrust, we may need to do a mild head tilt. Remember, life over limb. We need to make sure we can maintain an airway. And we may wish to, at that point, consider either an OPA or an NPA based on the mechanism of injury. An OPA would be ideal if the patient can tolerate it. If the patient cannot tolerate it, we need to consider an NPA. Be extremely cautious if the child has a possible skull fracture, a head injury, or facial trauma using an NPA. However, if the child's trauma is all below the nipple line, we may be able to use an NPA very successfully. We may want to consider emergent intubation based on the child's condition at that time, if the child's either going to need extended ventilation or if the child's unable to protect their airway at all. At this point, we may need to look at having to do that. Now, common indications for an emergent pre-hospital intubation: any suspected closed head injury which requires controlled hyperventilation. Any child who we need to do it to prevent aspiration, especially if they're unresponsive, unable to protect their airway. If we're unable to effectively ventilate with a BVM and an oral airway, and we need to do it to ensure ventilation. If we anticipate a need for prolonged control of the airway, for example, a 20 to 30 minute transport from your scene desk to the closest trauma center. Again, we may not be able to go to the closest community hospital. We may need to go further, in which case we may want to control the airway. If we notice a significant flail segment that's affecting the child's tidal volume and we need positive pressure ventilation, would also be a good reason to consider an emergent intubation in the field. Now, once we've managed the airway, we'll move on to breathing. When evaluating breathing, visually inspect the child's chest and abdomen, look for any open wounds, look for any paradoxical motion or signs of a flail segment, look for retractions, substernal and interclavicular, look for abdominal movement, seesaw movement, things like that would indicate struggling to breathe. At this time, we'll also evaluate the child's respiratory rate, and more so, the depth and breath sounds, and symmetry of chest movement. We can quickly palpate the chest wall for instability and crepitus, things that would give us an idea that potentially the child may be losing tidal volume due to chest wall instability. Now, if the breathing is adequate, we may wish to consider supplemental oxygen. We want to keep the O2 saturation 95% or better. It doesn't necessarily need to be 100, but if the child is struggling to breathe or having poor tidal volumes, we may wish to go ahead and administer supplemental O2. Now, if the rate or the depth is truly inadequate, we may at that point need to consider using a bag valve mask and/or an OPA to correct this deficiency. Evaluate for a possible pneumothorax. If a pneumothorax is present, we may need to address it. Now, if it's an open pneumothorax, i.e. a sucking chest wound, at that point we may notice bubbly blood coming out. Therefore, we need to go ahead and seal it. And we'll seal it with an occlusive dressing secured on 3 sides. However, it may not be an open pneumothorax. It could be a tension pneumothorax. A tension is a type of closed pneumothorax where, although the lung has got air escaping from it inside the body, there's no vent to the outside world. At that point, paramedic level would decompress it. When we decompress it, we're ventilating this excess air to the outside to assist in reinflating the lung on the affected side. Now, rapidly scan the child for breathing, for significant external hemorrhage. Control any significant external hemorrhage you find. Again, we're not talking little cuts and scrapes. We're talking flowing blood, pools of blood, things like that. Rapidly assess for signs of shock. Compare your central versus peripheral pulses. What is the child's skin color and temperature? Now, if it's a cold, wet, rainy night, cold skin could be normal. However, if it's a sunny summer day and 75, if the child's hands are ice cold and pale, that would give us a sign of shock. Evaluate capillary refill. With older children, we'd use the fingertips the same as we would an adult. If you're dealing with an infant or a neonate, you may have to use the top of the foot or the base of the foot with your thumb. Either one of these, again, will evaluate their perfusion status and their circulation status. Do a quick sweep for signs of internal bleeding. Typically present would be in the chest or the abdomen or the pelvic area. Do we see large bruises? Do we see large distension? Do we see rigidity that's asymmetrical, i.e. one side is different than the other and it's bruised and rigid? That would lead us to believe potentially damage to an internal organ is causing significant internal bleeding. Given the fact that that's not fixable in the field, we need to find a trauma surgeon ASAP. Now, as we move on into the disability or mental status exam, we determine the patient's mental status. One of the most common scales we'll use is the Glasgow Coma Scale, or the Glasgow Coma Score. This is a 3-part score based on the patient's eye opening, their verbal response, and their physical response, or their response to pain. You grade it on a scale of 3 to 15, 15 being perfect, alert and oriented, responding appropriately and obeying commands, and 3 being no response to any stimuli. The scale is listed here, but most of us have it either memorized or on our EPCR software. We're trying to get a gauge of where or how well the child is mentating at that point. Lastly, in the primary survey, we expose and work on the environment. We undress and expose the patient to quickly search for other injuries that we have not already seen or found out. Now remember, in the field, there's a fine balance between completing a thorough assessment and maintaining body heat and modesty on scene. Generally, if you do expose on scene, make sure you take the weather and the environment into account. For example, a child who is involved in an accident on a summer afternoon, it's warm outside, we don't have to worry too much about the environment. However, on the other side of that coin, a child who's involved in a sledding accident in a winter day, we may not wish to expose them while we're still sitting in a snowbank. We may wish to delay that or defer that until we're in the back of the unit. Now, by the time we've completed this primary exam and gotten a quick idea of what injuries we suspect or what's going on, we need to begin looking at our destination decision. Now, the destination decision is largely based on 2 halves. Number 1, where are we going? And number 2, what's the best way for the child to be transported there? Now, this is going to be largely based on your location, your jurisdiction, combined with the needs or potential needs you suspect for the patient. We need to remember when we do this, providers need to remember that the true care for significant trauma is surgical, and thus any patient with a significant mechanism of injury should be managed towards a facility that has surgical capability available. This may change based on time of day or evening. Some hospitals may be well-staffed with a team during the day, but may not have that available at all hours, or holidays or weekends. It's imperative that you as a provider maintain a good awareness of the capabilities of all the facilities in the area you serve. Combine this with what's the best way to get a child to that facility from various areas of your response district. For example, I've worked many years in a rural area. At certain points in our county, we're much faster to take a child to the trauma center by ground. Based on where we are, even calling the helicopter out, the helicopter, by the time they can lift off, get to us, land, exchange the patient, take off again, get back to the hospital, and then get inside, we could have already been there. On the other side of the coin, at the opposite end of our county, the helicopter would be much faster than we could be. They will go much more quickly than a ground ambulance will. On the other side of the coin, however, a helicopter will have time to warm up and take off if they're not already in the air. You need to base this based on your jurisdiction, your system, service area, and the resources that are available. Also, even if you rely largely on helicopters because you're in a rural area, what if they can't fly? What if they're down for mechanical? What if they're on another flight? So begin thinking of, okay, not only what's our primary method of transportation from this portion of our call area, what's our secondary option? Okay, this can be done a lot of times while we're en route. Where am I going? What are my first two choices of transport if this child needs to go to a trauma center? Much of this comes back to while we're responding. Can dispatch check on the availability of a helicopter? Is that something that's in your policies? Is the child entrapped and therefore the helicopter will have plenty of time to get there while we complete extrication? Or is it a child on a bicycle that we can literally immobilize quickly and scoop and run and be on the road to the trauma center in 5 to 7 minutes? We need to, again, maintain a good awareness of what our resources are, both for the hospitals and transport options in our response area, and work to achieve the best possible response to transport time. Now, as we initiate our secondary survey, in most major trauma patients, the secondary survey will begin once we're already in the back of the truck on the way to the trauma center or on the way to the LZ if we're using an air transport unit. This will be based on things, trying to locate things that we didn't find in the primary survey, anything that we missed, any details that we didn't get into. Many times this will be when we have a dedicated provider who's going to be with that patient for an extended period of time. It'll go through the history of the incident. It'll go through a detailed physical exam and a sample or CIM PEDS evaluation. Now, if managing a critical patient, this should definitely, again, be delayed or deferred until we're en route to either a trauma center or an LZ. It shouldn't be something that we stay on scene to do. Ideally, we want to be on and off the scene in about 10 minutes if at all physically possible. When we talk about the history of the incident, we're delving further into the situation. This can help us further refine our ideas regarding the mechanism of injury and the overall situation involved. Did the child lose consciousness at all? Were they ejected from the vehicle? Did they get out on their own? What exactly happened with the fall? Were they on the roof? Were they halfway up to the roof? How high up in the tree were they? Was there any intervening care on scene? Any care provided by bystanders prior to our arrival? Did a bystander place a tourniquet that we may not have already found? This can also help us paint a much better picture of the scene events and the precursor events to the receiving ER staff. So when we do our detailed physical exam, this typically is going to be a full head to toe, although in some cases we may have to limit it to focus on a specific injury or complaint. We want to obtain baseline vital signs, ideally blood pressure, pulse, respiratory rate, if we can get an O2 saturation level, and on a perfect day, we may be able to actually get an end-tidal CO2 level, sort of rated there in decreasing significance all the way down. I'll live without an end-tidal CO2 and an O2 sat, but we should definitely be able to get a blood pressure, pulse, and respirations. The detailed exam of the head. We want to look at the head and the scalp for any wounds, deformities, depressions, evidence of injuries. In children 1 year or less, bulging or protruding fontanelles may be an indicator of increased intracranial pressure. Remember, we talked about kids are really susceptible to traumatic brain injuries, closed head injuries. If we see this one, we know there was an impact to the head from a fall, and we see bulging fontanelles, that would definitely help confirm our suspicion for a closed head injury. Now, if you do find any brain tissue visible, go ahead and cover with a sterile soaked dressing. Inspect around the ears for damage, drainage, bruising, any injuries you see, anything coming out of the ears or cuts on the ears, bruising behind the ears such as battle signs, should all be looked for. When we look at the face, gently palpate the facial bones for deformity, for any tenderness or instability. Are the pelvic or the facial bones stable, or are they damaged? Do we have an eye orbit possibly damaged, jaw broken, things like that? Look in the eyes for foreign bodies or glass. Look for contact lenses. Look for wounds, the color of the sclera, any drainage from the eyes. And open and inspect the mouth for broken teeth or injuries. Do we see fluid, vomit, burns, anything that could possibly indicate we have a problem, that we may have an airway issue that we need to suction? Inspect the face, the mouth, the nose for soot or singed facial hair, especially if we're dealing with a possible burn issue. Gently palpate the posterior of the neck for any tenderness down the midline spine. Do we feel any tenderness, any step-offs, deformity, any point tenderness when we palpate? Look at the neck for wounds or bruises on the anterior and the sides. Is the trachea midline? Do we see any potential damage to the trachea? Any jugular venous distension noted? And again, do we see a stoma? If the child's unresponsive, we may not notice, so again, expose the anterior of the neck to look for these things. Expose the patient's chest, inspect for any marks or bruises or open wounds. Now, I know you've done this before, but it's a little bit later now. Could we have a bruise develop later? Yes. Do we see an open wound? Do we see any suspected open pneumothorax? If we've had to do a decompression before, is that still good? Do we have good breath sounds? Palpate for any subcutaneous air that may indicate either a tracheal tear or a bronchial tear. Evaluate the symmetry of air movement, equal expansion bilaterally. If we palpate the patient's chest and have them take a deep breath, do we feel any part of the chest wall that's not moving symmetrically with the rest of it? Look at the abdomen for wounds, bruises, distension. Again, you may have already looked at this initially when you did your quick scan. Now we have more time. We can palpate the quadrants for any tenderness or masses or rigidity. Now, if the patient does complain of pain in any of the quadrants, we'll work around to all the other quadrants first, and we'll palpate the potentially injured quadrant last. The reason for this is we know that palpation is liable to cause pain, so therefore we want to get all the no's out of the way first, as far as there's no pain anywhere else, but there is pain here. We know that any internal abdominal bleeding can definitely be a life-threatening surgical injury, and this would definitely make us think the patient needs more advanced care urgently. Now, as we work down to the pelvis, palpate the area gently for any point tenderness. Place your hands on the iliac crest or the wings of the pelvis and gently press inward. If there's no pain with any of this, gently palpate and press downward on the wings of the pelvis to evaluate stability. If you look at the picture here, for the most part, the pelvis is formed into one structure, or one pelvic girdle. If either side of the pelvis is moving independently of the opposite side, that would definitely lead us to believe we have a possible pelvic fracture. Now, absent a significant complaint of pain or bleeding, we may wish to defer any further pelvic examination or look at the genitalia until we get to the hospital. As we work through the extremities, palpate each limb, working from the most proximal to the most distal. We're definitely looking for wounds, tenderness, significant hemorrhage, but we're also evaluating the skin color and condition. Evaluate the distal pulse, motor, and sensory function of each extremity individually. Ideally, try to mark the pulse points in the lower extremities. This not only documents that yes, they were checked and present, however, it also tells somebody down the line that when they were checked, they were present at that point and can help a caregiver later in care palpate that area. They don't feel a pulse, and they know they're checking at the same location you checked. In most cases, absent either a significant exsanguinating hemorrhage, distal extremity injuries will not be our major life threat in this scenario. We're more concerned with things that are typically between the neck and the groin. Now, the sample or CIM-PEDS history. Sample is common. We use it on virtually every patient we evaluate. That's our signs and symptoms: allergies, medications, past medical history, last meal, last oral intake, and the events leading up to the incident. The CIM-PEDS, however, was developed by the Emergency Nurses Association and is geared more towards pediatric patients. The one big change in here, and while it's geared more towards medical patients, we may actually learn a lot as far as diet or diaper use, depending on how recent the wreck was and everything else. So again, taking a chance, do one of these, try to get this information assembled, as it will definitely pay big dividends when we get to the ER. So we've done all this, now what? Well, in a lot of ways, as we go into our reassessment, It's going to be more important than even the initial assessment. Okay, so we've done all this. Now what's next? Well, it's time to reassess. Now, in many ways, the reassessment can be more important than the initial assessment. First off, we know in the reassessment we can go back and look. Have we missed anything? Anything I didn't see or didn't notice? There was a lot going on scene. Let me go through again once more methodically, make sure everything's the same. Has something changed? Again, a child with abdominal injuries may have a slow bleed internally. Initially, they may have had a little bit of pain in an area, and now as we palpate the abdomen, we may find pain and rigidity. Is the patient's condition improving or not? Are what interventions we've done, are they working? Are they still in place? The oxygen that we put the child on, is it still enough? Do we need more? Are there injuries that weren't noticed at first becoming more apparent? Do we need to change an intervention? Do we need to change something that we're doing? And lastly, repeat vital signs allow us to do trend analysis. I often talk in medical classes, and I teach the question is a O2 saturation of 80% good? Well, a lot of people say, no, it's very bad. And I said, well, if we walked in the door 5 minutes ago and the patient had a sat of 70 and they were wheezing real badly, and now it's up to 80 and they're moving much better air, I can be very happy with it, 80%. By that same token, if we walked in, they were having trouble breathing and their sat was 85, and now they're struggling even more and it's dropped to 80, that 80% is very bad. So trend analysis of vital signs. Is their heart rate calming down? Are they quieter than they were? Is the blood pressure normalizing? Is the blood pressure down? Are they potentially bleeding internally? Again, trend analysis with vital signs can tell us a lot more than the simple snapshot can. If a picture's worth 1,000 words, a series of pictures can be worth 10,000. As we wrap up, we know that responding to pediatric trauma can present a unique set of challenges. Besides the obvious size differences, there are multiple significant anatomical differences. Basically, they're built differently than we are. And although it's not always possible, ideally providers should always endeavor to complete an initial assessment and at least one reassessment while en route. Now, time frame isn't always going to allow that, and in some cases you may be too busy dealing with one or two significant life-threatening injuries, and if we have to do that and not able to have a chance to complete the extremity secondary survey, we may have to live with that. We'll do the best with what we can, but by all means, if you're trying to manage a flail chest or trying to manage poor respiratory effort, we may not be able to always get to an extremity assessment, but we're dealing with a primary survey issue. So we can accept that and we go on. Hey there, I'd like to thank you all for stopping by, checking out our video. If you want more information about our company or any of the stuff we do, you can check out our website. If you need EMS continuing education hours, we do have our online education platform posted up there. Also, we have our email address if you have any questions. You can find us on YouTube, Facebook, Twitter, and Rumble. We maintain channels on all of those. Also, please like, share this out to your friends, subscribe, help support the channel, and we'll keep putting more videos out there for you. Oh well, enough about that. I know what I'm up for. Time for a cup of coffee. Y'all have a great day. Be safe out there. Bye.